patient, if taking gluten in the form of wheat, rye and barley, can develop celiac disease. What happens is gluten ingestion trigger an immune response in genetically predisposed individual. Who are the genetically predisposed individual? Who are having absence of this allele, who are having presence of this allele, HLA-DQ2 and DQ8, who are having presence of this allele. So what happened? Gluten ingestion, the tissue transglutaminase in our body or in those patients' body will deaminidate gluten peptide. The gluten peptide will be, gluten is a protein, so gluten peptide will be deaminated to increase their immunogenicity. So after deamidation, the gluten is now deamidated and the immunogenicity of those ingested gluten is now increased, and this gluten with increased immunogenicity will be produced to the T cell, will be presented by the T cell with the help of these allele which are present in this celiac disease patient. And now the activated T cell will release a cascade of reaction, will release the cytokine leading to inflammation and damage of the mucosa of the gastrointestinal tract. So simple diet was deamidated by tissue transglutaminase to increase the immunogenicity. The immunogenicity is increased, and now this gluten or deamidated gluten is presented by the T cell with the help of this allele, which lead to activation of the T cell and which lead to cascade of reaction, cytokine release, mucosal damage, inflammation, and ultimately the pathophysiological change which occur in patient of celiac disease is the villi get atrophy, that is the villus atrophy. The crypt become hyperplastic, resulting in flattening mucosa. So this is normal mucosa. Say the patient of celiac disease will have somewhat flat mucosa because of crypt hyperplasia. The crypt become hyperplasia, villus get atrophy, and which result in mucosal malabsorption and symptoms of malabsorption. So these are the pathophysiology: the villus atrophy, crypt hyperplasia, resulting in flattening of the mucosa. So if we look at the patient of celiac disease, wide variety of presentation. Remember this allele HLA-DQ2 and DQ8. Remember I ate 2 eggs at 8 p.m. So remember I ate 2 eggs at 8 p.m. Remember egg also contain gluten. I ate 2 eggs at 8. So remember this mnemonic to remember the allele which is involved or the genetic component of celiac disease. So usually the patient of celiac disease will have mixed type of diarrhea. We have discussed about osmotic diarrhea and secretory diarrhea. Osmotic diarrhea because of osmotically active substance present. Secretory diarrhea because something is stimulating the gastrointestinal tract, which is leading to fluid and water electrolyte into the lumen of the gastrointestinal tract, causing secretory diarrhea. So celiac disease patient will have a mixture of this pathology. Patient will have osmotic diarrhea also. Patient will have secretory diarrhea also. Why osmotic diarrhea? Osmotic diarrhea is because of malabsorption of fat. The destroyed villi cannot absorb the fat. Extra fat, extra fatty acid. Fatty acid is also an osmotically active substance. It will draw water, osmotic diarrhea. Why secretory diarrhea? Because the fluid, due to fluid hypersecretion from the hyperplastic crypts. So there was villus atrophy and crypt hyperplasia. So this hyperplastic crypt, normal crypt secreting normal amount of fluid, hyperplastic crypt will secrete more fluid and electrolyte. So because of hyperplastic crypt, there is more secretion of fluid electrolyte, leading to secretory component of the diarrhea. Osmotic because of fat malabsorption, protein malabsorption, fatty acid. Proteins are also little bit osmotically active, which will draw water, and the patient will have both the osmotic diarrhea and secretory diarrhea in case of celiac disease. The mechanism we have discussed, the clinical presentation, wide variety of signs and symptoms, wide variety of lab abnormality can present in patient of celiac disease, thus you have to keep an eye or keep an back of the mind diagnosis of celiac disease while treating iron deficiency anemia, while looking at the liver function test, while looking at the calcium and vitamin D deficiency patient, while looking at hypoalbuminemia patient, while looking at osteoporotic patient. So wide variety of signs and symptoms can be present in a patient of celiac disease. So differentiating, how you differentiate various mucosal syndromes. We have discussed celiac disease. The other mucosal syndromes can be Whipple's disease. Whipple's disease is caused by this organism. It is gram-positive rod. Tropharma whipplei infection causes Whipple disease. It is a bacteria gram-positive rod. It has a long diagnostic lag. Primary middle-aged man. So usually Whipple disease is an infectious origin of mucosal syndrome caused by this Whipple infection, which is a gram-positive rod. So usually clinical features are arthralgia and arthritis. Arthralgia, bone pain; arthritis, joint pain, pain and swelling. It is the usually symptoms. Gastrointestinal symptoms comes later during the course of the disease. That is why there is long diagnostic lag, because usually the patient present to us with arthralgia and arthritis most of the time around for years the patient can only have arthralgia and arthritis. So there is no gastrointestinal symptom. We will not think of any gastrointestinal pathology, but originally the patient is having infection of the gastrointestinal tract because of Tropharma whipplei. So migratory arthralgia precedes GI symptoms by years. Sometimes years the patient will have GI symptoms. CNS and cardiac involvement can also occur. We are discussing the patient of problem in the gastrointestinal tract can present with encephalitis, dementia, memory loss. The patient can present to us pericarditis, cardiac involvement. So all this problem can occur because of Whipple's disease. How you diagnose Whipple's disease? By doing a biopsy, endoscopy and biopsy. When you suspect this patient, do an endoscopy and biopsy, and in biopsy you get an periodic positive macrophage in lamina propria. You get an pass positive macrophage in the lamina propria. This is the biopsy finding. How you treat this patient of Whipple disease? Infectious origin, long-term antibiotic is required to treat the patient of Whipple disease. Tropical sprue is also a type of problem in the absorption caused by infection, or sometimes it is suspected post-infectious complication in some tropic regions. Not all whole of the globe, but some tropic region like India, Eco. So here the patient will have similar malabsorption problem. But here you can see simultaneously malabsorption of both folate and B12 deficiency. Simultaneously the patient can have malabsorption of both folate and B12. So, and in one condition, that is if there is small intestinal bacterial overgrowth, say suppose the patient is having SIBO, small intestinal bacterial overgrowth. So in that condition, what happens is that the patient will have B12 deficiency, but the folate will be high because the bacteria will produce folate. Small intestinal bacterial overgrowth, the bacteria which is overgrowing, extra growing, will produce folate, so folate will be high, will consume B12, so B12 will be low. So remember, SIBO, B12 is low, folate is high. But in tropical sprue, both folate and B12 are malabsorption. This problem in the malabsorption, not a problem in the bacteria. So both folate and B12 will be low. So tropical sprue presents similar to that of clinical manifestation is similar to that of tropical sprue. In fact, biopsy finding in tropical sprue and celiac disease was also same. But what is difference is that celiac disease you treat with gluten-free diet, because there is problem in the gluten sensitivity, immune reaction to the gluten diet. So when you treat the patient with a gluten-free diet, the patient improves most of the time. But tropical sprue patient does not improve with a gluten-free diet. So remember, tropical sprue is a brother of celiac disease. It is similar to that of celiac disease, both the clinical symptoms. Biopsy finding is similar to that of celiac disease, but it does not improve with gluten-free diet. So biopsy is again similar. There is villus atrophy, which is indistinguishable from celiac disease without clinical context, which means that when you treat the patient with gluten-free diet, does not improve. Tropical sprue improves celiac disease. The serology, when you do tropical sprue, TTG will not be present, but anti-TTG will be absent in tropical sprue. But in celiac disease, the serological test which is done is tissue transglutaminase, where you can see the tissue transglutaminase is the test of choice. So it's a screening test of choice to diagnose the patient of celiac disease. So tissue transglutaminase IgA type is positive in celiac disease and absent in the tropical sprue patient. So we have discussed about Whipple's disease, tropical sprue. Environmental enteric dysfunction is a rare variety because of patient in low income region can have low grade inflammation and malabsorption, and usually leads to childhood stunting, biopsy, crypt atrophy, and mucosal barrier dysfunction. Not